Hello, everyone. This is Kitty Lam, and my research topic is compliance with ferrous sulfate treatment for iron deficiency anemia, or IDA, among pregnant African American women in Los Angeles County. So first, my statement of research. Some important statistics for you is that anemia, unfortunately, is still one of the most prevalent conditions in the world, with 2 billion people diagnosed globally, 25% of our population. And 14% of these people have iron deficiency anemia, or IDA. The racial disparities, sadly, are an issue. And the prevalence of IDA for pregnant African American women is almost double that of non-Hispanic whites, or 40% versus only 21.4%. The risk for severe maternal morbidity, or SMM, is greatly impacted by IDA, and the two conditions are very much connected. And it's higher for all racial groups, this condition, than for non-Hispanic whites. The incidence of antepartum anemia, which is when the women are pregnant before giving birth, is 21.5% for African American women versus only 9.6% for non-Hispanic whites. So continue on with my statement of research. The severe maternal morbidity, or SMM, premature births, low birth weight, postpartum hemorrhaging, and intrauterine growth limitation are all conditions impacted significantly by IDA. And sadly, hundreds of women in our country still die from pregnancy-related deaths every year. In LA County specifically, which is where my study takes place, for African American women, 69% of pregnancies are unplanned versus only 40% for non-Hispanic whites, and only 73% of African American pregnant women get prenatal care for their first trimester versus 85% who get care of non-Hispanic whites. Many patients taking iron supplements experience digestive or gastrointestinal issues, and this may be affecting their compliance. Research on African American women's compliance, and actually just compliance in general with IDA treatments, is very limited. That's what I found in my research. Healthy People 2030 has set goals and objectives to reduce the prevalence of IDA, because this is having detrimental impact on people all over the world and in our country. The most severe conditions which can be caused by IDA are serious lung and heart conditions, which could be fatal. So this is just a literature map, mapping out visually what I did for my literature review. And I separated everything into subcategories, such as iron deficiency, anemia, IDA in pregnant women, and gaps in the literature. So my research question is, what is the perception of compliance with ferrous sulfate treatment for iron deficiency anemia, or IDA? So in discussing the literature review, I found many consistent findings in my research on IDA. Like I said, it's one of the most prevalent conditions in the world, and 14% of our global population has it. Anemia is most prevalent for pregnant women, 38% globally, and those with blood loss or heavy menstrual bleeding, HMB. Racial ethnic disparities, as I mentioned before, are major, and the prevalence of antepartum anemia, or AA, which is the condition of anemia before giving birth, is twice the prevalence for African American women as for non-Hispanic whites, 21.5% versus only 9.6%. Compliance with ferrous sulfate treatments is a big problem, with only 50% compliance due to the gastrointestinal side effects, which I mentioned before. I was really shocked when I found out from my research that only about 50% of the people who are prescribed the ferrous sulfate treatments are complying with their doctor's orders. So as far as conflicting findings, there were no significant conflicting findings that I could find in my research. And all of the statistics and the numbers that were reported about this condition seemed to be fairly consistent. So that was good. So in terms of gaps in the research, I did find that there were many gaps when it comes to researching IDA. There aren't enough studies done on this condition, and many of the studies were outdated. And they especially need more research on ethnic groups and how their specific response to ferrous sulfate is. And many more studies need to be done about compliance with ferrous sulfate, and especially for African American women who are the highest risk group. So the theory that I found, or concepts from this theory in the research for compliance with ferrous sulfate treatment, was the health belief model, or the HBM. So for methodology, my research design is basically a qualitative design, and I did a participant data collection. I used the health belief model as my guiding theory for every part of the study. I did qualitative interviews, one-on-one interviews, and of course, data collection and analysis and data interpretation. So for methodology, the first section is recruiting participants. This is the flyer that I created to recruit my participants that basically determine what their eligibility is. And so the first part of methodology is participant recruitment. So my sample strategy was based on the snowball sampling strategy, which basically meant as I was interviewing participants that I recruited, I asked them if they knew of other pregnant African American women in their same area that might be interested in doing the study. And for providers, the sampling strategy is basically reaching out to different places where I thought there might be a lot of pregnant African American women and getting their approval to put up flyers. So for recruitment and outreach, I thought of getting in touch with community centers that are popular in African American neighborhoods, African American churches, since the church is often a really important center for African Americans, and also posting up flyers with the permission of the Maternal, Child, and Adolescent Health Office in LA County, where many African American pregnant women would be making visits. And also posting up some flyers at the WIC office in LA County, where many pregnant African American women might be receiving services. And of course, at OBGYN clinics in neighborhoods with many African American women. So the eligibility questionnaire is pretty straightforward. It's a form that I would follow in screening them for the research by asking them some questions on the phone. And incentives offered was a $50 Trader Joe gift card after completing the interview. And so for data collection, it is guided by the HBM, or health belief model, as I mentioned before. And so these are some samples of my qualitative interview questions. For example, is there anything that makes it a challenge for you to take the ferrous sulfate as prescribed by your doctor? This would be perceived barriers. And what do you think are the benefits of ferrous sulfate supplements? So this would be their perceived benefits. So for data analysis, it would be analyzing the raw data from my one-on-one interviews, identifying and organizing themes, and interconnecting those themes. And interpretation of results would be interpreting the meaning of those themes, looking for patterns. And this includes, of course, my own personal views and biases in interpreting the results. So for validity and reliability, according to Creswell, validity must occur at every step of the study. And it's termed as trustworthiness, authenticity, and credibility for qualitative design. So it's important, Creswell says, to practice triangulation. So in my study, and because it's an ethnographic study, I would immerse myself amongst the African American community by hanging out at different community centers that are popular for them, maybe attending a church worship service in an African American church, and hanging out at the MCRA, Maternal Child Adolescent Health Office, and the WIC office as approved by the people who work at those offices because of HIPAA concerns. But hanging out at these different locations to make observations of the population and just do some informal information gathering so that I can double check it with my formal data from the interviews. And member checking, bringing my final report back to the participants for them to double check to make sure I got everything right from them. And of course, providing a rich description of my study, especially about the setting, including an honest discussion of my own researcher bias since I'm not from this culture. And finally, having a colleague in the same field do a peer review of my results. And for reliability, I would be the only one collecting the interviews or doing the interviews to have consistency in the data, and of course, double checking the data. So ethical considerations are pretty straightforward. I've been CITI IRB certified, and I would submit the whole proposal for the IRB to approve. And the participants have to sign my consent form. And limitations in this study. Because it's a qualitative study, of course, there are limitations in the sample because this is a convenience sample taken from a population of pregnant African-American women right within Los Angeles County. It is a relatively small sample size of only about 25 participants because it's a qualitative design. And of course, the results cannot be generalized. And as I mentioned before, there is, of course, researcher bias and reflexivity because my own values are reflected in the interpretation of the data. And also I could affect the direction of the study because as I'm conducting the interviews, the participants, if they sense that I have a certain perspective on what they're saying, it might cause them not to feel comfortable in honestly sharing about their experiences. So thank you so much for listening, and I hope that you learned something about iron deficiency anemia today.